Welcome to this session on pulmonology. It's my pleasure to introduce our speakers and proceed with the session. We have three interesting topics lined out. All these topics are relevant to current clinical practice. Our first speaker would be Professor Phan, who is no stranger to Sri Lankan audiences. Professor Phan has visited Sri Lanka many times, and in 2015, when he first visited Sri Lanka, he helped us establish the endobronchial ultrasound services at the National Hospital with Dr. Yamuna Rajapaksha, who trained under her, did her overseas segment in Australia, Adelaide. So over to you, Professor Phan.
Thank you, everyone. Thanks for the invitation. As I mentioned, I'm a respiratory physician in Adelaide, and this is my third Sri Lankan conference, but I hope the next one we get to meet face-to-face again. So I'll just share my screen. So I was asked to speak on diagnostic evaluation of pulmonary nodules. This aspect, I'll probably cover mostly things to do with nodules which are malignant, and we'll share with you some tools that we can use to assess malignancy risk. So the common one that we encounter as respiratory physicians are solitary pulmonary nodules. I'll cover some lung cancer screening data, nodule risk assessment tools, some surveillance guidelines, and I guess if time allows, we'll have a look at some of the fun technologies that respiratory physicians might be using in the next 5 to 20 years. I'll also cover a little bit on ground glass opacities, because I think these often cause us a bit of grief when we encounter them, and what to do about them. So nodule really is a focal opacity seen on CAT scan imaging. And by definition, it's less than 3 centimeters in diameter. It's a very common finding. In about up to half of adults who get a CT scan will have a nodule. A mass by definition is greater than 3 centimeters in diameter. And with the increasing incidence of CT imaging, and also in some nations such as the US and Europe with lung cancer screening, this is an aspect of respiratory life that we'll have to deal with a lot in the future. So the two major lung cancer screening trials would be the National Lung Cancer Screening Trial done in the USA, and that was annual screening with low dose CAT scan versus chest radiography for 3 years. The data is quite well published now, a relative reduction in mortality from lung cancer of about 20%. Up to a quarter of the screening group had imaging suspicious for lung cancer, but of note, 96% of the detected nodules were subsequently found to be benign. More recently, the Nelson study, which was a Dutch-Belgian trial, finally was published in the last 1 to 2 years. And the addition here was the use of volume doubling time, and CT scanning was done at slightly different intervals, but they also found improved mortality risk and lower false positives by using the volume doubling time rather than just the diameter. So those were the two major trials which have prompted some cancer societies around the world to recommend cancer screening. I find that the PanCan or the Brock model is quite useful in day-to-day practice. So this was developed by Annette McWilliams, who now practices in Western Australia. So the two data sets were initially the PanCan data set and then the British Columbia Cancer Agency data set. So the BCCA participants were the validation set. The PanCan data were the prediction set. So in both groups, a specialized radiologist reviewed the low dose CAT scans. So any non-calcified nodule or non-solid density of at least 1 millimeter in diameter was considered abnormal. A benign nodule had a calcification pattern or was deemed to be stable over 2 years. So they looked at nodule size, the nodule type, whether it was non-solid, ground glass, part solid, subsolid, solid, or around the fissure, the lobe location, and spiculation. Age, gender, and family history were also looked at, and of course, smoking history and the history of emphysema. So the PanCan prediction set were more than 2,500 participants and had 3-year follow-up. 102 or 5% of the nodules were malignant. And in the validation set, this was 1,000 participants who had 5,000 nodules and 42 lung cancers overall. So variables that were consistently associated with lung cancer were older age, any emphysema seen on the CT scan, and evidence of COPD or lower percent predicted FEV1. Other variables which were consistent were size, type, location of the nodule. So upper lobe nodules tended to be high risk, but peripheral nodules were almost always not malignant. Speculation in the PanCan dataset was also found to be a predictor for malignancy. So in the end, the model which was developed, and there are apps now that you can put these details into. It's also found on UpToDate and also the BTS. But female gender increases your risk, the size of the nodule, the location, speculation, age, family history, emphysema, nodule count, and the nodule type. So these models are well established, and there are websites that you can use to put nodule risk into. So I sometimes use this when I have a new patient with a nodule, and it does help with giving them a risk prediction when you try to counsel them about what the best management plan is. So here are some of the graphs showing size, which increases your risk of lung cancer, the bigger the size, essentially. So an example is if there is a 5% risk of cancer found from the model, the sensitivity is about 70%, the specificity is 95, and the negative predictive value 99.6. So very good negative predictive value. So it's accurate for even small nodules. Upper lobe increases your risk. Peripheral nodules you can tend to relax about. But if there is mediastinal or hilar lymphadenopathy, then you can't really use this model. And sometimes the largest nodule isn't always the malignant one. So usually a second scan is needed to determine growth rate. So two of the radiology societies which have released guidelines include the American College as well as the Fleischner Society. So this lung CT RADS system or lung RADS system was updated in 2019. And again, you can find this resource fairly easily available online at this web address, but they classify nodules into different risks of malignancy. So negative being less than 1% risk, benign appearance or behavior less than 1%, probably benign, so 1 to 2% risk of cancer, suspicious being 5 to 15%, and very suspicious being greater than 15%. So I've just done some screenshots of the PDF that you can download from that website. But essentially, your nodules under sort of 5 or 6 millimeters, I tend to tell patients you don't need to worry too much about those. If there's a ground glass opacity, which I'll cover a little later, that's under sort of 30 millimeters with no solid component, then the chance of that becoming malignant is also very low. So there's an increasing risk as the nodule increases in size, in particular if there is growth on a subsequent scan. Solid nodules sort of greater than 6 or 8 millimeters, you start to get a bit more nervous when they reach that size. But also if there's a non-solid nodule such as the ground glass opacity with a solid component that is reaching sort of 5 millimeters or greater, then those kind of nodules you also do worry about a lot. So once you get past that 15 millimeters or a significant solid component in a part solid nodule, then that does become very suspicious for cancer. So the difference between the lung RADS and the Fleischner Society is Fleischner used their guidelines for incidentally detected lung nodules rather than cancer screening nodules. So their guidelines, if you do use them in your day-to-day practice, you just need to remember it doesn't apply to lung cancer screening scans. It doesn't apply to patients younger than 35 years. It doesn't apply to patients with a history of cancer, and it doesn't apply to patients with a history of immune suppression. And they classify the nodules into either single or multiple, or single and multiple with a ground glass or part solid component. So again, this is available from the Fleischner Society website as well. So for the solid nodules, this was last updated in 2017, and I'm sure there'll be another update very soon. So for a single solid nodule under 6 millimeters, then the risk is extremely low. So if there's a high risk patient, so if you pop into the model, if they're high risk, such as with a family history or smoking history, then you might do an optional CT at 12 months. If there are multiple nodules and they're under 6 millimeters, then surprisingly, the more nodules there are, and if they're quite small, then usually that's almost certainly benign. So usually you don't need to follow them up. Again, if they have a high risk factor, then you might do a CT at 12 months. So if you look at these sort of guidelines for small nodules, I'm probably guilty of this, and probably many of us are guilty of this, but I think a lot of us probably overscan. If you look at some of these guidelines here for the low risk, less than 6 millimeter nodules. For the high risk nodules, when you reach 6 to 8 or greater than 8, then sort of a 3 to 6 month scan tends to be the general recommendation, plus or minus a PET scan if you're particularly worried. So the ground glass ones are always a little bit harder, I think, but if there's a ground glass component less than 6 millimeters, then generally the risk is very, very low. The difference with ground glass opacities is if you start to get more ground glass opacities, then they may have a tendency to be one of those patients who potentially might have an adenocarcinoma in situ. So you would probably consider a 3 to 6 month scan in that situation. Once you do start to get to that sort of greater than 6 millimeter or greater than 8 millimeter size, and you might want to do a more frequent scan, either at 6 to 12 months and then every 2 years until 5 years, or some societies might recommend to you to do an annual scan for the ground glass ones, which are greater than 6 millimeters. This was a very good editorial in 2017 by Detterbeck, which addressed these ground glass opacities. My general practice for them, if they're sort of greater than 5 or 6 millimeters, is to do an annual scan. If they are purely ground glass with no solid component, then you could get away with just an annual scan. Once they start to get either a 5 millimeter solid component or greater than a 50% solid component to the ground glass area, then that's when you start to think this could transform into an adenocarcinoma. And in those situations, you would need to either investigate further, or in some countries, such as in Southeast Asia or Japan, they may even go to resection without attempting biopsy. So those sort of two factors, 5 millimeter solid component or greater than 50% solid component to the ground glass area, then you do start to worry that they will transform. You follow those two general rules, then you will almost never miss a stage 1 lung cancer, according to this data set that was published back in 2017. So the main thing is to go back as far as you can, not just the last scan from 6 to 12 months ago. Look at the solid component, especially if it's greater than 50% or if it's greater than 5 millimeters. And in some countries, such as Japan, they may jump on them as soon as they reach 15 millimeters or greater, even if there is no solid component. But the Fleischner Society is a little bit more conservative, and the Lung RADS Society is a bit more conservative, and they mention a sort of a 30 millimeter diameter with no solid component. So how do we reach these things? I always have to mention CT guided biopsies first, before I mention the respiratory methods. CT guided biopsies, the diagnostic rate is very good, but I always say there's a selection bias, which isn't such a bad thing. I mean, if you approach a radiologist, they'll either tell you yes or no, whether they can reach something. And if you do have a selection bias, then obviously your rate is always going to be higher. And I think that's why a lot of the published rates are greater than 90% in the literature. There can be an up to 20% pneumothorax rate, but depending on the institution, there may only be a 5% or so intervention rate for those, as many times the hole is quite small and you can leave them alone. CTFNA versus core is always a question. I guess if the patient is surgical, then you really just need a few malignant cells, and then you can run all your ancillary tests on the surgical sample. But if they're non-surgical and if they're for systemic therapy, then I think a core is probably better, so you can run all the extra ancillary tests that you need to do. So I guess with airways and nodule access, the complex thing is that there's a lot of airways to try to reach nodules. So as a respiratory physician, this can always be quite difficult. There's a lot more options if you're trying to go by the airway. So there was a very good review article by Fielding and Ockey in Respirology this year, looking at how you might reach it with a bronchoscope. So bronchoscopes have slowly developed in technology. So they're now able to make quite small bronchoscopes with a fairly decent working channel. So the smallest one with a decent working channel would be the 3mm with a 1.7 channel. So you can pass radial probes or biopsy forceps down them. The one that I tend to gravitate to is the 4.2 with a 2.0mm channel. Now, as the scopes have gotten smaller, you're able to reach further, and you can use navigational tools, peripheral needle aspiration, peripheral cryobiopsy. And I guess the centres with more money are starting to look at cone beam CT and robotic bronchoscopy. So these are the navigational tools. Even with navigation though, even with virtual navigation in a meta-analysis, it still is about a 70% to 75% diagnostic rate. With ground glass nodules, some centres, the expert centres, may reach 70%. I use just a manual method of mapping the airway taught by Professor Kuramoto, and using that, my last sort of audit was about the 75% mark here in Adelaide. So this is your radial ultrasound probe. So the thinner one works down a 2.0 channel. This is the thicker one, which you need the 2.8 channel. And this probe is about sort of 1.4, 1.5 in diameter. So that can reach quite far out, all the way to the periphery. So you pass your tools down a guide sheath with the forceps and brush pre-marked, and that way, once you take out the radial probe, you can take biopsies from that area. So the ultrasound gives you a 360-degree image, and that can, once you're in the lesion, it gives quite a distinctive image, and you can take biopsies directly from that region. And you locate the lesion based on the CT and your anatomy or a virtual bronchoscope image from software. You pass the probe into the lesion, remove the probe, leaving the guide sheath in place, and then take samples from that region. That's a graphical image where the transducer is in the tumour. You take out the transducer, leave the sheath in place, and then use your forceps to take biopsies. So this is a quick video example of a left upper lobe lesion that we did. So I'll just walk down there. This is the endobronchial view, your left main bronchus, left upper lobe, lingula here, anterior segment here. And the lesion was in the left upper lobe 1+2 segment or apico-posterior segment, which we had pre-drawn from our map. So once you pass the probe into the lesion, you get quite a distinctive ultrasound image from your biopsy location there. So yield can be affected by size, whether the probe is adjacent or within the lesion, and the location of the lesion. So left upper lobe is usually the most difficult, and Kuramoto showed that by taking 5 pieces, then your diagnostic rate tends to go up. There are now disposable cryoprobes which can fit down guide sheaths. So the 1.1 can fit down a thin guide sheath. The 1.7 you can put down a smaller 2.0 bronchoscope. Now, I find these quite useful if you're adjacent to the lesion, so you can freeze the tissue adjacent to it and then take the sample that way. So these are some of the cryoprobe pieces that you can get from a random transbronchial biopsy. This is a endobronchial hematoma, which we removed, and this was a foreign body from someone who aspirated their dinner one day. I've only got sort of 1 minute left here, so I'll just quickly cover some machines which are now coming into place. One is the robotic bronchoscopes, and two is also Archimedes. Archimedes uses software to create a tunnel so you can go across the lung to get to a lesion. So it uses a map to show you where the spot is. Then if there's no direct airway, you create your own airway to get into the lesion by putting a needle into the airway and dilating it with a balloon. Like so. And then passing your probe directly across the lung into the lesion. So it's like doing a CT guided biopsy, but from the inside. So in terms of robotics, my PhD supervisor did the first human trial in Australia. So it was a 3.5 millimeter catheter with a 2.0 channel. The robot, once it's in place, it has a memory technology, so it stays in place and it can move up and down and back and forth. So you can pass your tools down this channel. So once you've put the robot into the spot that you want, the robot will just stay there. And it's controlled by a controller like an Xbox controller. And you can pass your forceps or brushes down that channel and the robot doesn't move. So I guess the problem with normal bronchoscopes on humans is that you often will fatigue and your scope might move out of place or the patient might move. So that's why I think sometimes our yield is not as good. So just before I guess we finish, because I'm slightly over time now, this is the robot in place, being navigated towards the lesion. And once it's on target, it tells you the distance that you need to go with your forceps. And you can target the lesion directly. So the robot stays very, very still. That's the kind of setup that we might see in the future, where the bronchoscopist is standing at the screen and the patient's intubated and with II in place. So nodules are common, most are benign, risk assessment tools are quite useful. Technology is advancing fast, but I think there's still a role for the basics of anatomy. And I think institutions in the future will probably need to be pragmatic on how to best invest in nodule technology. So I'll leave it there and open the floor to questions.
Thank you, Fan, for that excellent talk. I have a question. It is about the fissural nodules. When you were talking about the follow-up of nodules, now you said like a nodule in a fissure, which is most of the time it is benign, and the recommendation is to go for a CT at 1 year. So if you find at 1 year that it has not grown at all, do you continue to monitor it or do you just let it be?
I usually let those ones be, the periphyseal ones, because they're often always benign, thankfully. So I normally might just do a 1 year scan and then leave it at that.
Thank you, Professor Fan. In a country like Sri Lanka, where we see a lot of TB and post-TB granulomas, and sometimes aspergillus-related disease, where we're seeing solitary nodules or multiple nodules are not infrequent. Most of these are solid nodules. What are your thoughts about these nodules in patients in countries where TB is endemic, and how important is the ground glass components to these nodules?
I think in endemic countries, such as Sri Lanka, Vietnam, where I was born, the granulomas are sometimes a bit easier to evaluate because they might have a little bit of calcification in them. So that, I think, is always a little bit of a clue. I think the complicating factor is if you have a female patient who has ground glass but also has granulomas elsewhere, it's difficult because you almost have to evaluate each nodule on its own merit. Because with females, they're more likely to have, the non-smoking females are more likely to have the ground glass nodules. I would evaluate each one on its own merit in a way, but probably be more concerned of the ground glass ones. The solid ones, which are sort of under 6 or 8 millimeters, I'd probably be less worried about those in endemic countries.
Okay, thank you very much. Thank you, Fawn. It was nice seeing you. We would
Yeah,
like
good
to
to see
see
you.
you back in Sri Lanka and wish you all the best. Thank you.
Thank you.
Fine.
See ya.
Our next speaker is Dr. Amila Ratnapala. He's a consultant respiratory physician working at Teaching Hospital Kandy. And he's going to talk to us about optimizing clinical outcomes in ILD. I'd like to add that Amila has a special interest in interstitial lung diseases. Over to you, Amila.
Thank you so much. I'll share my slides now. Yes, so first of all, I'd like to thank the Ceylon College of Physicians for their invitation to discuss about the interstitial lung disease. So today I'll be discussing about optimizing clinical outcomes of interstitial lung disease. First of all, I'd like to discuss a few clinical problems before discuss about the clinical behavior of ILD. So first of all, the 27-year-old pregnant lady with the 12th week of gestation presented with acute shortness of breath for about 3 weeks duration. And as you can see, there are some opacities in the HRCT, and she was extremely breathless, and initially she was on CPAP.
Amila,
and then, yeah.
Amila, you are not sharing your slides. Can you please share your slides, please?
Okay.
Yes, we can see your slides.
Right. Yeah. So I'll start with few clinical problems. So, I mean, my first lady is a 27-year-old pregnant lady with 12 week of gestation, and she presented with acute shortness of breath. As you can see, her HRCT shows some opacities, diffuse opacities in the lung, and she was very breathless, and she was on CPAP at the time of presentation. And this lady is a 64-year-old lady with seropositive rheumatoid arthritis, and she was on methotrexate, and she was presented with MMRC for breathlessness. She was breathless at rest. And this 65-year-old gentleman, again, it's slightly progressive breathlessness for about 1 year duration. And as you can see, the CT scan shows different patterns of lung opacity. So there are 3 different patterns of lung opacities in 3 different interstitial lung disease. So what will be the outcome of this patient? If you get generally, if I plot their symptoms in y-axis, and if their time of disease in x-axis, and if you could plot the severity of symptoms, and you can see that patients expect that they will be better soon. So as you know, breathlessness is a very difficult symptom to tolerate. So they want early recovery from breathlessness. So their expectations are very high generally. But in reality, we know if we do not intervene appropriately and timely, the reality will be like this. There will be either worsening of symptoms or even death is a possibility. So therefore, it is very important to intervene appropriately and early and rationally. So in certain group of interstitial lung disease, for example, like fibrotic ILDs, predominant like idiopathic pulmonary fibrosis, if we intervene appropriately early, we might be able to curve up like this. And in certain interstitial lung disease like this, for example, like idiopathic NSIP or fibrotic HP, if you do the appropriate interventions, we might be able to stabilize the lung without any further progression. In certain interstitial lung disease like acute interstitial pneumonia or organized pneumonia, when there's a high inflammatory element, that we might be able to reverse the lung volumes very soon. We might be able to improve them even to the pre-existing or precondition levels. So this is the rough idea that I'm going to discuss. So, but the most important fact is that we have to intervene appropriately as well as early to achieve these outcomes. Otherwise, the reality will be very sad for these patients. So what matters the clinical outcome? What are the factors which will lead to a better clinical outcome in interstitial lung disease? My dear ladies and gentlemen, diagnosis is the most important factor that we have to think, which will definitely affect the outcome of these patients. So, for example, this study published in CHEST 2014 by Strand and group, they found that if you have a diagnosis at the disease onset, in certain conditions like idiopathic pulmonary fibrosis, which carries poor prognosis, as you can see in this green curve, and if you go for the other purple or other curves, you can see then in connective tissue disease associated interstitial lung disease that the prognosis would be far more better. So when to suspect interstitial lung disease? I'd like to emphasize that uncontrolled asthma, most of the patients, even my first case, she had breathlessness for about 3 months, was managed as asthma. So uncontrolled asthma is one of the commonest presentation of interstitial lung disease. They have cough and breathlessness. Most of the doctors and most of the physicians, they treat as asthma with inhalers, but they're not responding. So when a patient comes to you with uncontrolled asthma, it is very important to look into other etiologies like interstitial lung disease. The second is unexplained right heart failure or pulmonary hypertension. Again, interstitial lung disease plays a significant role there. In addition, a significant family history. For example, if there is a family history of lung fibrosis, so not only that, short telomere syndrome like cryptogenic cirrhosis, aplastic anemia, premature graying of hair, these syndromes are associated in the family. It might be indicating that you are dealing with a familial IPF. So it is very important to look into these family history as well. And each and every patient with connective tissue disease, I'm going to stress the fact this ILD can be associated. So therefore, in a patient with CTD, when they come with breathlessness, please auscultate their lungs and evaluate these patients with further investigations, because there might be interstitial lung disease associated with. And other is patients with exposures like smokers and organic or inorganic dust exposure like farmers, bird fanciers, and people who are kind of exposed to silica, asbestos. This group of people is a significant exposure history in their occupation. So that is again a group of patients that we should keep in mind regarding interstitial lung disease. Ladies and gentlemen, again, I would like to stress the fact that examination matters. So most of these patients, if you carefully auscultate their lung bases, you will hear the fine inspirated crackles, and you often miss if you do not kind of expose them appropriately and auscultate appropriately. So therefore, auscultation of the lung as a clinician when a patient comes with breathlessness is it's mandated, and it is very important. And also careful auscultation of the precordial area, especially looking for kind of a loud second heart sound or any additional murmurs. That is also very important. And please look for CTD features too, because interstitial lung disease or lung fibrosis could be the presenting feature of a CTD, because most of the CTDs, they can manifest from the lung. So there's a thing called lung dominant CTD, or we now call IPF, or interstitial pneumonia with autoimmune features, that you might have disease onset in the lung. So therefore, looking for subtle CTDs, like for example, nail fold telangiectasia and early signs of skin thickening and etc., is very important when you're examining a patient with shortness of breath. This is a study published in BMC Pulmonary Medicine by a group of researchers. They have emphasized the fact that acoustic characteristics of fine crackers is predicting certain CT features like honeycombing with a significance. So therefore, it is very important as a clinician even a general practitioner or as a general physician to have a thorough examination on these patients. So next important diagnostic tool is high resolution CT scan of the chest. I think we should arrange it without a significant delay. These days we have a significant technology like multi-detector CT scans with volume acquisition, and we have certain softwares like MIP and MINIP that we can kind of identify the lung very clearly, as well as these HRCT patterns. Now they positively correlate with the histological patterns. Therefore, the histology is far more less useful these days because of this advancement of the radiology. And if in inconclusive cases, actually, still we do pathology in these patients in forms of bronchoalveolar lavage or transbronchial crush biopsies, and they are evolving to the transbronchial cryobiopsy, as my previous speaker told. It's not available in Sri Lanka yet, and ultimately surgical lung biopsies. However, the surgical lung biopsy carries a bit of significant mortality. This is a study done in Sri Lanka. Actually, we carry a mortality about 8% and a morbidity about 13–15%. Therefore, I mean, when comparing the renal and liver biopsies, our diagnostic, as a diagnostic procedure, surgical lung biopsy carries a high risk of morbidity and mortality. Therefore, we recommend not doing routine surgical biopsies, and if you are doing a biopsy, and the patient should definitely undergo a multidisciplinary team meeting with radiologists, pathologists, as well as the expert in ILD, pulmonary fusion, and then come to a conclusion whether this patient requires a surgical biopsy or not. And the next most important diagnostic tool is a multidisciplinary approach. I mean, it is happening in Sri Lanka, but not in a kind of ordinary way. But that is very important. Now it is almost like evidence-based medicine. This study published in Raghu et al. In 2018, and he studied about 1,000 patients who has undergone single disciplinary approach versus multidisciplinary approach. They found patients who are diagnosed with by a single disciplinary method. About 30% of these patients, they have undergone unnecessary diagnostic testing, as well as they were on incorrect therapy. Therefore, MDD or multidisciplinary team approach is one of the fundamentals in managing interstitial lung disease. So if I summarize, as a clinician, as a general physician, or as a pulmonary specialist, or a general practitioner, when a patient comes to you with breathlessness, either uncontrolled asthma or patient with significant exposure, CTDs, I think this algorithm is very important. The first most important aspect is you should define the clinical context, because as a clinician, that is very important. And if we can identify the etiology by the history alone, and if you can't, actually we can go for these patients. Next step is go for a HRCT without a delay. And most of the time that we have a diagnostic pattern, if we do not have a diagnostic pattern, next is actually we can go for a basic pathologic investigation after MDT discussion. And with all this information, we are coming to a multidisciplinary team meeting, and there we can come to a confident diagnosis or working diagnosis and offer treatment without a delay. And again, it is very important to assess these patients longitudinally, because that, and then feedback to the MDT team, because that disease behavior has to be discussed in MDT, because that sometimes that we might have to alter our management strategies. And the next most important aspect is early treatment matters. It is very important to offer your patient treatment without a delay. In certain centers, I know that the CTs are delayed for months and months, but still, I think our ILD patients, because most of the lung volumes that they are going to lose might not be recovered because of the fibrosis. So it will preserve your lung volumes, therefore the quality of life and patient's functional status will be preserved when you intervene early with appropriate treatment. And also they found that it will delay the time to acute exacerbations in their interstitial lung disease. So this is a study done in America, and it is published in Thorax 2017. This is, I mean, this study, they have compared patients with lung fibrosis, especially IPF, with FVC more than 90%. That is forced vital capacity more than 90% means they are very trivial, or they are maybe asymptomatic patients. And compared with the patients who have FVC or forced vital capacity less than 90%. In this group, you can see that the milder group or patient might be asymptomatic in this group, and still they have preserved lung volumes about 133 ml after 1 year. So for example, decline in the placebo group is around 224, in the treatment arm with nintedanib that is about 91. So about 50% of the lung is preserved when you offer treatment at the early stage when you do these longitudinal assessments. And also assessment of initial response, that is really important. It is not that I know that most of the time we have a practice that once you have a diagnosis and then the subsequent visits, we do the continuous aim in 1 month continuous aim, second month continuous aim, like that. So it is not the case in interstitial lung disease. We should assess their initial response clinically, radiologically, as well as physiologically. For example, a chance CT in 3 to 6 months time is important in these patients, along with their functional assessments as well as lung volumes and the 6-minute walk test. We should know the disease behavior early because we have to intervene to this disease behavior, and otherwise we will result in a poor outcome in these patients. And again, this study published in 2018, and they have found that patients who responded initially within 3 months, they have a better prognosis than to the patients who have not responded initially to the effective treatment. So I'll discuss about some real life study because we have effective treatment. Most of the modern treatment is available in Sri Lanka, and most of them are available in government sector and few are available in the private sector. But remember this, most of the novel drugs are available. So none of the interstitial lung disease we are not managing conservatively without any treatment. So all these drugs are available. So these are some real life studies. Actually, these drugs are very efficacious as well as they are safe. For example, perfenidone, you can see that before patients are started on perfenidone, you can see that they have a decline and it was stabilized with the treatment. And if you get the nintedanib, you can see before starting treatment, they have a progression and then it has been stabilized. And if you take nintedanib in systemic sclerosis ILD, that is fibrotic type of ILD, and you can see that nintedanib has reduced the rate of progression of their lung volumes. And if you take in all the interstitial lung diseases, irrespective of the etiology, and when they're progressing with fibrosis, whatever the etiology, this antifibrotic nintedanib will reduce their progression. So this is irrespective of the etiology. When there's a fibrotic element and it is progressing, nintedanib reduces the rate of progression, whatever the etiology. So, and this is another study done in UK, and it's about tocilizumab in systemic sclerosis. As you can see, lungs are preserved, lung volumes are preserved with tocilizumab compared to the placebo, but this skin, there's no significant benefit on the skin. And this is a study on rituximab in antisynthetase syndrome, that is a myocyte spectrum interstitial lung disease. You can see there's a significant response in patients with interstitial lung disease with myocyte spectrum ILDs. Again, the safety, most of these drugs are really safe. In real time, about 80% of the patients will have some side effects, but they are mild and can be managed significantly. In clinical trials, that is around 98%. And if you take nintedanib, again, about 90% of the patients, they have some side effects, but they can be managed in a specialist center with the expertise. And this is the ILD model that we are managing our patients from the time being. You know, each and every ILD, there's an inflammatory response initially for example, active disease. At the time of the active disease, we go for disease-specific immunomodulatory therapy. For example, like immunosuppression with steroids, mycophenolate, azathioprine, or whatever the drugs, and then with rituximab, like biological agents, or tocilizumab. So this is very important to preserve the lung volumes. And then when it is progressing, so if you're detecting a delay, when there's a fibrotic phase, still we can offer antifibrotic therapy, whatever the etiology here. So it is like your CKD, and initially we try to use disease-specific therapies, and when the disease is progressing, irrespective of the therapy, we can add on antifibrotic therapy to save the lung volume. Not the last, but remember, quality of life as well as quality of death is very important. Not only all these interventions that we are doing as a respiratory physician or a general physician, but we should think about their quality of life as well as the quality of death, because that is a part of a clinical outcome. For example, as you can see, when a patient with interstitial lung disease comes in, we should discuss about the supportive measures with their patient as well as their family members, caregivers. the supplemental oxygen, the pulmonary rehabilitation, education, or psychological support, and again discuss about the side effects and the effects of this disease-modifying treatment, which include antifibrotic therapy, immunomodulated therapy, or if possible, going for a clinical trial. And the symptom relief, again, is very important because none of these disease-modifying agents like antifibrotics, they do not affect your symptoms. So therefore, you separately have to manage their symptoms of shortness of breath, fatigue, cough, and anxiety and depression is very important. And timely, we should discuss about the end-of-life care and the treatment limitations, as well as about the death. If I summarize, again, to improve the clinical outcome, we should have a clear diagnosis, and we should intervene appropriately and early in their time of interstitial lung disease, as well as we should assess their initial response, as well as we should think about their quality of life as well as quality of death. For that, we have this ABCD approach. If I am summarizing, we have to assess the patient needs and values, the patient and as a partner in care, and also we should back with education. We should advise them to self-manage, certain like diet, nutritional management, and support groups. And we have to consider pulmonary rehabilitation, and we have to recommend vaccination. We have to comfort and care and look into the comorbid conditions like dyspnea, cough, and fatigue, as well as we have to think about their comorbid conditions like ischemic heart disease and other comorbid conditions. You have to manage them appropriately. And then we have to think about the disease modifying agents. We have to discuss about the side effects and so on. And we have to discuss about the end of life care, which include we have to discuss about their fears, their practical needs, the palliative options, and about limitation of this resuscitation and ventilator support. And I'd like to acknowledge all my trainees, and I'm very glad to present this lecture. And thank you so much for listening. I'm happy to answer if there are any questions. Thank you so much.
Thank you, Amila, for that excellent presentation. We are running short of time, and we have to stick to time. So we have to move on to the next speaker. Thank you, Amila.
Thank you so much.
Thank you, Amila. Our next speaker is Prof. Anup Chauhan. He's a consultant respiratory physician at Queen Alexandra Hospital, Portsmouth, and also the Associate International Director of South Asia. It is my personal pleasure and privilege to introduce Prof today, because long years ago, I was his trainee as a respiratory